Precision Opinions Live with Christian Stella, Pharm D. And today I'm here with a special guest, Dr. Anita Sadaty. This is actually the first time we're going over Zoom, and I like it, trying to get adjusted to it, trying to figure out all the buttons here. But so, Dr. Sadaty, thank you for coming on. I appreciate it.
Oh, my pleasure. Happy to be here.
Yeah. So it seems like last year we were at an event, and time has that was pretty much a year ago.
Yeah, it was at the beginning of COVID.
Yeah, that was at the beginning, and now here we are over Zoom wearing masks. So it's a different lifestyle. But I'm here with Dr. Sadaty, pretty much Cornell University, OBGYN, functional medicine at IFM, right? Certified. Yep. Okay.
Mm-hmm.
And your office, which is Redefining Health, founded by yourself, 55 Bryant Ave in Roslyn, New York. So I want you to kind of, for me, if you can describe the practice and your path of medicine. So why you chose kind of the functional route at Redefining Health, and explain what you do for your patients.
Sure. So I've been an OBGYN for almost 25 years. And was in private practice prior to opening my current practice for 20 years, doing tons of deliveries, lots of gynecology, surgery, very busy practice. We were delivering about 1,000 babies a year just amongst the 4 doctors. And basically, about maybe 10 years ago, I started realizing that what I had to offer patients that were not pregnant. You know, with pregnancy, it's a little more straightforward, but in my gynecologic practice, I started noticing that I didn't necessarily have enough tools in my toolbox to really address a lot of the issues that women were experiencing, especially 30s, 40s, and definitely in the 50s with menopause. And that's when I started getting interested in alternatives to conventional medicine. And obviously what I mean by conventional medicine is just, you know, your typical medical doctor, allopathic medical school and residency, which, you know, now in retrospect, I realize is definitely a medication-based practice. And it doesn't really look into more natural alternatives or lifestyle issues that impact health and wellness and well-being. And so I started becoming more interested in that side of healing, and started learning about things like bioidentical hormone replacement and vitamin therapy, and, you know, a lot of alternative ways to manage symptoms and issues. And eventually, you know, after 20 years of delivering babies, I sort of decided, you know, I think I've done enough there. You know, and I want to open up my own practice and really focus on women's health issues and offer them, you know, a wider array of choices in terms of how they can manage their hormone symptoms.
Oh yeah, and it's interesting too, because you have probably the best background. I know that a lot of physicians that are in this integrative functional space, they're coming from all different angles, but you're really coming from that OBGYN background, which is nice because you know the hormone background probably better than anyone, you know?
Yeah, I think that it's definitely a leg up, because you realize how critical hormones are to health. And when they're not right and they're not balanced, it can really create very wide-ranging symptoms and problems. So yeah, I feel lucky that was my background.
Yeah, you know the balance better than anyone. So, leading to kind of our discussion today is going to be bioidentical hormones, and I just want to know from your idea, your perspective, what bioidenticals pretty much are, and how you explain it to a patient.
Yeah, well, you know, it's really interesting, because I'm sure you get this as well, Christian. You get a lot of misinformation. You know, patients are not necessarily, you know, they don't necessarily understand at all what bioidentical means. And it's actually very simple, you know. So bioidentical means that the hormone that you are being prescribed or that you're taking is exactly identical in structure to the hormones that the human body makes. So if you were talking about bioidentical estrogen or estradiol, which is probably the biggest, most important of the three types of hormones that women make, you're getting estradiol or you're getting estrone or you're getting estriol. Like those are the three subtypes that we make. If you're doing testosterone therapy, you're getting the exact same structure of testosterone that your body understands. It knows how to process it. And the same for progesterone. So it has nothing to do with, does it come from a yam? It doesn't have to do with, is it necessarily something that can only be compounded, that you can never find that in a regular pharmacy?
And that's what I hate too, when people when people talk about, and I'm sorry to cut you off, but when people talk about bioidentical hormones, they put it under a classification of compounds. There are so many different products out that are out right now that are bioidentical, but people just associate compounding with bioidentical hormones.
Yeah, it's definitely misinformation about that, because it just strictly talks about what the structure of the hormone is. That's it. So as long as it's identical to what the human body makes, then it's considered bioidentical, whether it's made in a lab or comes from a natural source or it's synthesized. It doesn't matter if the end product is biologically the same as what your body makes, then it's bioidentical.
Perfect. All right, good. So now you obviously have the OBGYN backgrounds, so you've seen all this different menopausal symptoms that you could see. Is there some that are more common? What are you seeing the most in your practice when it comes down to symptoms, and kind of like what are you having the most success with as well?
Mm-hmm. Well, the thing that gets the most airplay for menopause, of course, are the hot flashes and the night sweats. I think that's probably the top symptom that really bothers women. And, everybody sort of makes jokes about that, like with the red face and the sweating and the windows open and the temperatures, at 50 degrees in the house and things like that. So that's definitely one of the most common symptoms that we experience when you're moving into menopause. I'd say that the second one, which is somewhat related to the hot flash and night sweat disturbance, although it doesn't have to be, is insomnia. Another big one is anxiety and depression and mood instability. And weight gain, of course, women definitely find that they start developing more weight around their middle when they lose their estrogen and progesterone. They experience a lot of brain fog and mental lapses and some fatigue. So those are probably the top symptoms. Another big one actually that I have found since COVID has been hair loss. That has been exaggerated. Yeah. And you've seen that too, right?
Oh yeah, of course. And especially when the stress level goes up, that's when the hair falls out.
Exactly. Yeah. So even though there is a association with the infection itself, that hair loss can be one of the symptoms that you get related to COVID. It's much more related to the magnified stress level that people are experiencing.
Correct. Yeah.
So those are probably the top. Of course, there are things like low libido, vaginal dryness, and that actually is at the top too. Vaginal dryness and painful intercourse is huge. That's really high on the list of things that women complain about in menopause. But it's helpful to kind of think about it in terms of the different types of hormones and what you're losing. So if you have estrogen deficiency, if we look at estrogen, for example, and you put that in a box, you're going to see hot flashes and night sweats and irritability and dry skin and insomnia and depression and mood swings and forgetfulness and the vaginal dryness and heart palpitations. Another thing actually a lot of people don't realize is you also get some increased allergies from estrogen deficiency. Yeah. But then we also have testosterone deficiency symptoms. So that's where you're going to see, I think, more of the weight gain and more libido and anxiety, depression. Also, muscle pain or lack of muscle growth, like you can't put on muscle with exercise. More belly fat, definitely gaining weight around the middle. And I think loss of focus and drive. You become less, I guess, sure of yourself and less focused on your task, less concentrated, less motivated. So those are typical symptoms of the testosterone arm of hormones. And then finally, with progesterone, that's our feel-good hormone. And so that helps to reduce inflammation in the body. It helps to improve sleep. It helps to reduce anxiety. It's really a calming calming hormone because it impacts the GABA receptors in the brain, which is all about sleep and calm and relaxed. So progesterone is also very important. It doesn't get a lot of play.
Does not get as much play as Xanax, and and it could do the same thing because it can really hit the same receptor,
Yes, yeah. I mean, I agree with you. I think that instead of Xanax and Prozac, progesterone should be what they're handing out and heart palpitations, right?
Oh yeah, of course.
That's another one with progesterone. A lot of women, when I was in my other practice, I had a ton of women who were like, oh, I was in the emergency room the other night because I thought I was having a heart attack. My heart was beating out of my chest. I was anxious. I felt pain. I went to the emergency room and they thought I was crazy. Everything was normal. They said, you're just having an anxiety attack. And meanwhile, that is just plain old lack of progesterone.
Mm.
So, yeah. And it's interesting because I feel like cardiologists probably need to get in on that.
Cardiologists, yep.
Yeah.
I mean, you look at all of these hormones and they do have receptors in. Estrogen has about, I'd say, 150 to 200 different receptors all over the body, everywhere. So they're affecting every single motion your body goes through. But I mean, I like to kind of break down. There's so many different ways of breaking down what sort of symptoms correlate to what hormones. I like to do it exactly how you said, by each hormone, and it's the easiest to explain it to a patient that way. And also primary and secondary, I think, is fun too, because we know that some symptoms could be a lot easy to treat, and I would put those in a primary standard, and the secondary could be the ones that are a little bit hard or associated from the primary. But yeah, it comes down to what they're deficient in and how you're testing, and I love that. I love the way you broke it down. And as you broke it down like that, just like the different hormones, there's different ways you could deliver these hormones to get different results. So what formulas would you say? Creams, capsules, I know there's troches, there's all different types of forms, and you know it just as well as I do. We're the ones sitting here making it, but you know exactly what we're making. So which ones do you prefer for which symptoms, certain symptoms?
That's a really good question. And I think that, everybody is a little bit different in terms of where, how do you want to approach this? So for example, if I have a patient who really the majority of their symptoms are related to vaginal health. So dryness, painful intercourse, difficulty with orgasm, urinary incontinence, overactive bladder, urinary frequency. If it's very much pelvically related and they're not so much struggling with, let's say, hot flashes or night sweats or sleep disturbance or anything like that, and they want to be more conservative in their approach to estrogen, then I would work vaginally. Then I would love a cream, an estrogen cream or a DHEA cream, or a combination maybe with that and testosterone, depending on whether or not there's libido and orgasm issues. So there's a little bit of a concoction there, but the nice thing about it is that it works very locally. So if somebody is concerned about hormone exposure for whatever reason, or they want to avoid as much hormone exposure as they can, then that's a beautiful solution to just use estriol vaginally or estradiol vaginally. And you can add some DHEA, which also converts to estrogen, or sometimes use DHEA alone. And then testosterone plus or minus, depending on whether or not there's issues with incontinence or orgasm or libido. So in that situation, I'm happy to use a suppository. I'm happy to use a cream. I don't, or even a tablet, if someone's concerned about how messy it might be. I actually have a question for you there, because I do have patients that do like tablets vaginally. Do you think that there's something better about doing a tablet or a suppository or a cream if someone's just going to do local vaginal care?
It's funny you say that. We actually make a rapidly dissolving tablet that is a very, very small tablet, maybe the size of a Tic Tac, that goes intravaginally. And the difference between this and a suppository is this tablet, it dissolves a lot quicker, A. B, you don't need to put it in the refrigerator. So certain suppositories you do need to keep in the refrigerator. So this is something that the patient can keep in their pocketbook and travel, and they can use an applicator as well. But we know that the absorption when using a hormone vaginally is so great. This is something that is awesome. The cream could drip. That's why applying it locally and applying it to the labia might be a better option. But if they don't like to insert and they don't like the whole drip factor, the tablet is the best way to go. And it's becoming more and more popular nowadays.
Yeah, I agree. I think most women are far more interested in using a tablet internally, because exactly it. They don't want to deal with the dripping and the discharge in the morning or whatever. Of course, if you do want to do something on the outside, then the cream would be superior. So that's where I would say cream would be a nice option. And then if you were talking about someone who wants to do hormone replacement for estrogen deficiency symptoms or testosterone symptoms, now you're talking about, well, how do you want to apply it? Orally, or do you want to apply it transdermally? And there's a tiny bit of controversy about that, but certainly the majority of OBGYNs are going to want estrogen transdermally.
Correct.
And that could be, in the form of a patch, that could be in the form of creams or gels. Progesterone, again, so there's, you can use topical cream for progesterone, which even that can also have some calming properties and sleep properties. But if insomnia is a huge issue, I much prefer, and I feel a little more confident using oral progesterone, because I feel like that delivers a little bit more as far as uterine protection, because you do need to balance the estrogen with the progesterone to protect against any kind of growth activity in the endometrium, like precancer. But it's also a dynamite in terms of the metabolites that then the allopregnanolone, is that what it's called? I don't even remember.
Allopregnanolone.
Pregnenolone, there you go. Okay, so it breaks down into that, and that is great for sleep and calming. But I have heard, and I do have patients that prefer the cream, and they feel like they do get some benefit as far as sleep goes, even with that. What are your thoughts there?
Yeah, so as far as using it for insomnia, a capsule, you're not going to beat a capsule. Cream could work, but it's all about that conversion. The gut helps it convert into that 4-allopregnanolone, and that's really where that molecule is going to latch on to GABA and really help the patient relax for anxiety or help them go to sleep at bedtime. And then it comes down to whether you're making that capsule immediate release or sustained release. So if the woman is going to sleep and waking up after 3 hours, a sustained release capsule is a better option. So they're going to have a delayed release, slow throughout the night. Let's just say 8 hours of progesterone that's being all converted into 4-allopregnanolone and latching onto the GABA receptor. But some women, they just react differently to the capsule. So they do want to use the cream, and the cream does work. It definitely does.
Yeah, I mean, I was surprised actually to hear that, that they do feel like there is actually some calming and sedating effect. I was really always under the impression that either sublingual drops or troches or oral was sort of necessary to get that effect, but who knows? I mean, I guess there's something about the having the progesterone molecule intact and not metabolized that may have some separate effect, outside of the allo what allopurinol. I
Oh
can never
man.
remember that.
No, it is
Hey,
all
yeah.
okay.
What do you
But
think about oral estrogen? Using oral estrogens.
oral estrogen, I mean, it it does when it goes to the gut, you can have more 4-hydroxyestrone, which
Mm-hmm.
we really, really don't like. And I'm sure you're running some urine metabolites at your office, and
Mm-hmm.
you're trying to move those metabolites in different areas.
Mm-hmm.
So I'm not crazy about it for that reason. Certain women really do need it, so it's okay. And especially, like I said, if you make that capsule sustain release, it will reduce that. But always, the hand to write an oral estrogen, I think, to me, is the hand to write an endol 3-carbinol. They need to go together, or a DIM,
Mm-hmm.
just because you want to reduce that metabolite. But that,
I think
I mean,
that's a great suggestion.
yeah,
Yeah.
if the patient always, if the patient needs it, you just need to keep a watch on that metabolite, you know?
Mm-hmm. Yeah. I agree. I rarely do oral, honestly, if we're just for whatever reason not able to achieve the symptom relief with transdermal, then you can and I think it can be done safely, like you said, adding a DIM product or calcium D-glucarate or something that's going to help bind out excess estrogen and try to push the pathway away from 4-hydroxyestrone
Yeah.
metabolites. You can do, which I do often anyway with hormone replacement. A lot of times I'll have patients, especially if they're perimenopausal, I'll have them do some sort of liver support in that situation.
Oh yeah, of course.
Yeah.
So, what about some of the side effects you see with these hormones? Um, are they bad? Are you telling and educating the patients about these side effects beforehand? Are you adjusting? So, what's going on with that?
So in an ideal situation, I mean, if I could ideally monitor somebody the way I'd like to, then I would love for patients, once they start hormone replacement, to do something like a urine metabolites test so that we can really see what's going on when their body is faced with hormone exposure. Are they breaking down their estrogen in the safe pathways? What does their methylation look like? What is their breakdown of testosterone? Are they doing 5-alpha products or not? So where how do things land there? But it is an expensive test, to be doing frequently. It's not covered by insurance, so it's a little bit, it's not that accessible for a lot of patients. So blood work can be helpful to try to just
Oh, of
see
course, yeah.
if we're making a dent in terms of the safety. Are they in range? Do we see that we're bumping up in their levels? Are they in a safe range? And then we correlate that with their symptoms. So we're not going to treat a lab. We are going to treat symptoms, but at least we get a sense, are we making any dents in this for this patient, or are we already kind of on upper level of range, and maybe we might need to look for different ways to manage symptoms. So that's always ideal.
It's like a big safety net.
Yeah,
Yeah.
yeah, so it's just nice to know where they're ending up when we start adding hormones. But yes, I think that educating the patients about what the potential side effects is huge, because especially depending on how long you've been out of menopause, like how long you've been out of getting periods, the receptors are completely empty. And of course, because you have decreased estrogen and progesterone, testosterone, your body tries to increase the number of receptors on the cell surface all over your body. So they're like ready and waiting for, for hormones to occupy them. And so a lot of times I warn patients in the beginning, listen, you may actually start feeling some symptoms of almost like you're about to get a period potentially. It's not necessarily that the dosing is too high. It's just that your body hasn't been exposed to hormones in a long time. And so you're going to have more of an exaggerated effect. So sometimes it's a matter of like, let's sit with this for a week or two and just see how things flesh out. But in general, I'm going to warn patients about high and low symptoms. So for example, if your estrogen's too high, then you're going to look for things like breast tenderness or breast enlargement, or maybe nausea, maybe headaches. You might get some water retention or swelling. You might even get potentially some staining or breakthrough bleeding. In that case, of course, I would definitely want a patient to get a pelvic ultrasound. I think within the first 3 months of hormone replacement.
That's the OBGYN background in you.
Yeah, exactly. I'm quick with the ultrasound.
There you go.
Yeah, but the good thing is that it's very reassuring. You show your patient, look, your uterus is fine, your lining is fine. There's nothing to see here. It's just that you're going to get, the uterus also responds to hormones. So excess, like I said, the breast fullness, the tenderness, water retention, weight gain, maybe moodiness, maybe irritability, maybe bleeding, pelvic pressure. So that would be maybe if the estrogen's a little too high, we might want to dial back. Same thing with progesterone. So interestingly, with progesterone, if it's a little too much, then I warn patients, you might feel excessively tired or sleepy. You might get water retention as well. So sometimes progesterone gives us, they call it paradoxical reaction. So even though progesterone is supposed to help prevent breast tenderness and prevent bleeding and prevent water retention, sometimes people get what they call a paradoxical reaction, where you get the exact opposite symptom. So it can be almost like estrogen excess, but I feel like if they're very woozy, if they're kind of dizzy, if they're really tired and groggy, then there's probably too much progesterone on board. And then with testosterone, I'm very careful about going low, starting low and going slow, because if you start developing symptoms of testosterone excess in a woman, you're not happy. Like you don't want the teenage acne back, you don't want your voice to deepen, you don't want excess hair, where you don't want it. And, there are a lot of symptoms if you go too aggressively with it that can happen. Luckily, most of those things are going to reverse very quickly, as soon as you stop it and reduce the dose. But it's better to just go slow and find the right dose for you.
Oh, I love it. Good. Well, I think this is a nice way to close. I really, really appreciate you coming on and sharing your secrets. You gave us all your secrets. Now we know how to run your practice. What are you doing?
I'll just close my practice.
Yeah. But thank you for coming on, Dr. Sadaty again. 55 Bryant Ave, Roslyn, and the number is 516-801-1313. That's correct, right?
Yes, yeah.
And drsadaty.com, right? Is there any other information you want to throw out there or at all?
No, I was just about to say that I have a lot of information on my website at drsadati.com, as you just mentioned, and I write blog posts about a lot of women's health issues. It's on my website called Share the Health. And, I try to inject a little humor in them, so it keeps you reading. But I also just wanted to thank you, Christian, for the work that you do and how supportive you are to my patients. And I'm sure to all the doctors who refer to you, they have nothing but praise as far as your customer service, your knowledge, your support with things that they need. So I thank you as well.
Oh, thank you. Thank you for the nice words, and thank you for coming on.
My pleasure.
All right.
Be sure to search Precision Opinions Live on Stitcher, Spotify, YouTube, and Google Pods. And make sure to follow Precision Pharmacy on Instagram, Facebook, and all other social media platforms.